Liezl came up from South Africa, longest distance traveling. Liezl, you are well experienced with the vacuumet, you are well experienced with your specific subject, patients suffering on chronic.
Well, thank you for having me here, all the way from South Africa. 2 weeks ago, I was in Krakow, Poland, for another conference as well, so it's 2 times in this hemisphere in a short period of time. So, from South Africa, I would like to just introduce you to our center. I have a multidisciplinary center where we focus on wound healing. That's my specialty. I'm a wound management specialist. I've been doing this for 18 years and probably longer before that as well, but focusing on the diabetic foot. Okay, slower, sorry. That's my South African speaking fast voice. I'll slow it down. Okay, so when you see that I go too fast, you just go, you know, the stop sign, and I will go slower. Okay. So in South Africa, in my center, we have a team involved. I do have a general practitioner. We have vascular surgeons, not at the clinic, but based in conjunction with the clinic. Orthopedic surgeons working with us. At the clinic itself, we have a physiotherapist team, biokineticists, we have orthotists, podiatrists, dietitian. We also have diabetes educators involved in the center and endocrinologists. So for us, we do see also sports injuries, but my speciality and why I'm talking today is specifically to introduce you to what we do with wound care. Okay. So I use in my facility the vacuumet system, and like Professor Orletsky just said, it's the same device, it just has different settings. It's about what you want to achieve. So you can use the vacuumet for sports injuries as well. Just the same with the VacuSport for medical purposes. It's the programs that differ. So if you understand the programs, you know which one you would like to choose. Okay. So just to show you, even my family uses the vacuumet. That's actually my son playing games while getting therapy. And he's 14 years old, so you can use it on younger people as well. So just to introduce you to what I'm going to talk about, first of all, we're just going to look at normal wound healing phases. We're also going to look at why don't wound heals, and why do we use IVT? What's the reason behind using that? I'm also going to discuss the e-poster that I did last year at the European Wound Management Conference, and as well, I brought some extra current cases that I'm very excited about last minute this week to show you, because that's really significant for me in the environment that I work with. And probably the photograph, I'm going to discuss this specific case a little bit later as well, is very significant. This patient lying in the vacuumet and his leg next to the vacuumet. And he's got one remaining leg left. For me as a wound care specialist, and especially working in diabetics, to save a limb is what I live for. If I can make sure that we lose less limbs across the world, it would be my everything. Because as we sit here, every 20 seconds, a limb is lost due to diabetes in the world. So just think about it. Just while I'm trying to talk slowly, we've lost 3 limbs. Okay. And that's the severity of the world that I work in. Okay. Okay. So I'm not going to show you the video clip about the wound healing phases. I'm just going to talk about that. But if we look at the normal wound healing phases, we've got an inflammation phase, we've got the proliferation phase, and the maturation phase. Now, even though it's a sports injury, it all works the same. Every single injury, whether it's a wound or a sports injury, will have an injury phase followed by an inflammatory phase, and then the healing occurs. What's important here, Gabriel, just the next, is that we have to do a holistic approach. You cannot just look at the patient in isolation. We need to look at everything. So what do we do when we look at a holistic approach? We work with a paradigm called the Wound Bed Prep Guideline. Now, in this guideline, and you can always look at previous presentations that I've done for Weiergans. Those are available on the website as well, and you can see a little bit more about the wound healing paradigm. But it's about treating the cause. It just doesn't help us to put on a plaster. It's not going to work. It's what's going inside in the body of the patient, but also their comorbidities. If they are diabetic, if they've got hypertension, cardiovascular disease, all of those, have an impact on wound healing. We also need to look at your patient concerns. So if the main concern for the patient is pain, that should be your focus area. In wound care, a lot of the times the concern is odor, because wounds, if they're infected, we've got an odor problem and we need to treat the bacteria and the infection. Then, of course, we need to look at, is this at all a healable wound? If your patient has a malignancy, you cannot expect that wound to heal. And certainly, IVT is not a miracle healer for cancer. Even though I think a lot of us would like to add that to the list, if we can. It's also important about moist wound healing. So to choose the correct products and choose the correct method in which we deal with wound healing. And very, very important, even though it's mentioned last, every single person is an individual. If we are not going to treat patients as individual with the individual needs, how can we get a better outcome? So when we look at this, I like to put it in a paradigm to say when we talk about treating the cause, we need to talk about VIP. And VIP is vascularization, infection, and pressure. And the last bit is then the healing that we do. You can go to the next one, Gabriel. Okay. So if we look at VIP, certainly what we first found in wounds is hypoxia. Okay. It can either be due to the injury, which stimulates the inflammatory phases, or it can be to poor vascularization. Both of them has the same effect. It can also be due to infection. Now, as you can see from the photograph on the screen here, this is a diabetic patient where we take the temperature of the foot as well. If you look at the foot plainly, it would not look that bad. But the moment you take the temperature, if I have a foot with 39.2 degrees Celsius, it's not Fahrenheit, it's Celsius, that foot's in trouble. Okay. So this patient had actually underlying osteomyelitis. And then the last one that we've got is pressure. Now, when we look at pressure, and here I would like to actually address why we use negative wound pressure therapy and why we use also IVT, intermittent therapy. It's also about pressure, and pressure actually increases flow as well, or decrease flow. So what you need to decide, if it's going to be a patient where the result or the reality why the ulcer there is because of pressure, in a diabetic patient it might be because the patient's walking on the ulcer the whole time. You cannot expect healing if a patient's walking on the wound the whole time. It means that we need to offload and recreate perfusion to that area. So I'm also part of the World Alliance of Wound and Lymphedema Care. We do projects across the globe. Just go back one slide for me, please. Okay. And these are the basic wound care principles that we align with. So number one is you need to protect the wound from trauma. Now you can see from the bottom picture that's a diabetic patient, already had some amputations. His other leg is amputated. He's a high-risk patient. But at the moment, there are too many forces on that foot. There's trauma, repetitive, because he keeps on walking on that foot. He's got severe neuropathy. He can't feel. Okay. So he does not realize what he's doing. He wore a shoe too tight, okay, which caused, again, ulceration. So if we don't protect that foot, he's going to lose that one as well. The second thing is that we need to promote a clean wound base and good infection control. It doesn't help us just to put the best technology available on the market, wound care-wise, on that patient wound. We actually need to follow basic principles. Wash the wounds, wash the leg, and clean the area first. The third thing is maintaining a moist wound environment. Now, the whole thing about wound care is that we mimic the normal functions of the skin. So we want that protection, we want blood flow, we want a safe environment where new cells can proliferate. And we do that through moist wound healing. And it's not the desert, well, I almost said the desert. In South Africa, my South African translation sometimes gets lost. So I had this one conversation at a conference talking about the desert, meaning the dry area, you know, Sub-Saharan or Saudi Arabia, wherever. But I got confused between the dessert and the desert. So yeah, just to make clear, we're talking not about the dessert that you're going to have after lunch. We're talking about the desert, too dry. Okay. We don't want that in our wounds either. Number 4 is that we would like to enhance systemic conditions. Now this is where Vacuumed or IVT really comes in handy. Because if I can actually enhance the patient's systemic condition, their general well-being, but their blood flow and their lymphatic flow, I get a better result. And of course, number 5 also fits in with the Vacuumed or VacuSport. Control peri-wound lymphedema and edema. The effect that we have with this technology is what's making a difference in my practice when we deal with wounds. Okay. So why IVT? First of all, increased cardiovascular flow, and you've heard more than enough about that. Vascular regeneration. Now for me, that is so important in a diabetic patient per se, that we get new angiogenesis, new blood vessels there. Increased microperfusion in the peripheral venous system. For me, probably one of the cases in South Africa where I was really very happy with the fact that we have IVT there, is that when a vascular surgeon that deals with hyperbaric oxygen therapy referred a patient to me saying, Liezl, try this machine just to see if you get better perfusion so that we can use hyperbaric oxygen therapy. Ironically, the patient reacted so well, he didn't need to go for hyperbaric oxygen therapy, and we got him healed faster with fewer sessions. Needless to say, the hyperbaric center does not want to refer patients to me anymore because we get them healed faster at the moment. Okay. We also have accelerated lymphatic drainage. And in wound care, the lymphatic system is often not recognized for the value it plays in wound healing. Now, we've already seen earlier this morning the reasons why IVT works so well, the cell proliferation. It also helps with your bacterial defense, angiogenesis, the collagen synthesis, everything we need for healing is what it does for us when it improves flow. If you think about the lymphatic drainage, I talk about the cleaner or the vacuum cleaner getting rid of everything that's not supposed to be there. You can see the removing of the waste materials, the excessive metallomatrix proteases we see in wound healing, but we see that in sports injuries. You've got a buildup of lactic acid that you would like to remove. The sooner we remove the byproducts or the leftovers, the faster that wound will heal, irrespective whether it's a diabetic foot ulcer or a sports injury. Okay. And then the enhanced inflammatory response. I often refer to it when I speak to my patients and telling them about Vacuumed therapy is that this is your kickstart. This is getting your life back, telling your body to get back into its normal rhythm and setting the baseline again. Okay. So this is just the summary which I presented last year at EUMA, the European Wound Management Conference. In the end, this electronic poster won an award at EUMA, and also back in South Africa, we won an award for the work that we've done. We saw 82 patients. You can go to the next slide, Gabriel. It was a study group of 82 different patients. We had 33 diabetic foot ulcers, 31 vascular ulcers. We had 4 lymphedema cases, 4 post-operative non-healing wounds, and we had also 10 athletes with ligament tears and muscle tears. So what we did, we wanted to evaluate what the impact was of IVT in these different cases. The patient selection criteria was very simple. We looked at patients who had delayed wound healing for more than 2 months. We also included the different type of wounds, diabetes, vascular insufficiency, neuropathy, trauma, and post-operative. Also your first to second degree ligament tears. We did normal wound care according to the wound bed prep guideline, and we also did IVT, where it was 30-minute sessions, between 4 to 10 sessions, depending on what was needed for the patient. This is just an example, which to me was quite a good example to show you what we can achieve. If you look closely to this picture here, on the first picture when we started it. Now, the cause, this is an elderly patient. You can see he's 78 years old. He's got severe rheumatoid arthritis. He went for reconstructive surgery, so we've got instrumentation in the toes to straighten those toes and to help him walk better. The problem post-surgery was that we had wound dehiscence, we had infection, and we had open instrumentation. So normally when you have open instrumentation, everybody's thought is we need to get the instrumentation out, it's not taking, it's a higher risk. In this case, we said, no, let's give it a chance. Because for him, going back to surgery was very traumatic. The other concern was these two toes, the fourth and the fifth toe. As you can see here from the K-wires that's there, this K-wire tended to turn and actually cause a pressure ulcer between these two toes. So what you've got at the fourth toe is a pressure ulcer in between the toes because of the K-wire. So the main concern for this patient was, I'm going to lose either just my toe or maybe my whole foot because of what is happening. So we've got a problem with perfusion, we've got a problem with pressure, and we've got infection. So all of that was part of the case history. What we did at the clinic, we tried to actually turn the K-wire. You can see here, every time you turned it though, it will migrate to its original position and again cause the pressure. So we wanted to leave it in as long as we could, and we managed it by actually putting foams in between the toes and helped him with that. The protocol was standard wound treatment, where we used a topical antimicrobial dressing, and we used also antibiotics. And we did every day a session in the vacuumette for this patient of 30 minutes. Okay. And you can actually see here, within a month, look at the result. From that picture to here, and then subsequently 2 months later, we had complete healing of that area. No surgery, no nothing, he's walking, he's fine. Okay. Gabriel? Okay, so these are some of the results that are presented at UMA, just some summaries. The first one that you see here was a failed skin graft due to trauma. This was a traumatic injury where the patient was attacked by a dog, and had subsequent muscle loss as well. Unfortunately, here she was referred to an orthopedic surgeon who decided he's going to try his reconstructive surgery methods on her, which unfortunately failed, and we had dehiscence. But with 10 sessions of vacuumette further, basic wound care. We didn't do much about wound care. It was honey, and it was a dressing that can absorb the moisture. And you can see the result. The second one here is trauma post-op with a patient that had fractures of both the radius and ulna, if you can see on the far side there. The biggest concern for that patient again was the edema. Unfortunately here the surgeon decided to do a skin graft on an area of granulation tissue that was hypergranulation tissue and did not need a graft. He just had to get the swelling down beforehand. But you can see the results just from the IVT sessions that the edema decreased and even the scarring is less in this patient. For cosmetic reasons, we would like to actually excise that scar because that is an unnecessary piece of skin that's there. Third patient here is just venolymphedema. Just to show you, it was not daily done, but in 10 days, 5 sessions, look at the difference in the legs. Of course, what's important, we do use compression hosiery afterwards to also help these patients maintain. And then the fourth one that was presented at UMA was this case of a patient following osteosarcoma, which they amputated the leg. The problem with her at this point in time, if you look at the first photograph, she had severe edema of that area. She also had a hemocele there that actually accumulated a lot of fluid, caused immense pain to this patient. Previously, before we did IVT, she was already admitted 2 times to theatre where they opened her up again and tried to drain. This time around, we didn't take her back to theatre. We just managed the area. We put her in the vacuumette 4 sessions in 6 days, and this was the result. And I'm happy to say that she got her new leg this year. She's walking, she's fine, she's cancer-free, and here they said to her that they can do nothing for her. So she's really an exceptional case. I added these photographs purely for the sake that it's a new audience and you maybe haven't seen these before. This was also part of the study. Just to show you in 7 days, this was a traumatic injury. You can see the skin tears on the hand as well. But just look at the difference. 3 IVT sessions, 7 days, and this was the result. She couldn't come in for more because of where she came from and the traveling distance as well, so we combined it with the wound care treatment. But you can see that's quite a significant results that we had there. Next one, Gabriel. This is an older patient of mine from a study from 2014, but I just wanted to show you without any surgery or debridement in theatre what can be achieved with Vacuumed. And this is a patient with an ABPI of 0.7 and has severe lymphedema as well, and this was the result. Okay. Next slide. We talked earlier about neurological complications following a cerebrovascular incident, and what I wanted to show you specifically with this patient here. This patient never had any other additional therapy, but what was significant with the vacuum arm starter was specifically, if you look at the color of his hand before and after treatment. Gabriel, just go back. So can you just see the discoloration here and the bad perfusion as well? But just look at it afterwards. And what was very significant after the session is that the patient was able to move better. It was not complete movement on his own, but there was definitely an easier way of movement and rotation of the hand specifically. What was also, for me, probably one of the best results was the patient's face after the therapy, when he saw that his hand wasn't purple. I think we underestimate also the psychological impact when patients feel better because their pain's better. If you also feel better and you feel positive about your treatment, you will also heal better. And there is definitely a psychological impact in a patient. So in UMA, the conclusion that we presented there was that it definitely made a difference, a significant impact on overall healing time of the wounds. All wounds healed much faster than expected. The decrease in pain levels were very significant. And till this day, this is probably the one thing of IVT in wound management that really makes a big difference. So the quality of life of patients improved. We also see the edema decrease that was very significant. And then what to me is something that I'm still very interested in is the changes in neuropathy. So what we see with patients is that my diabetic patients are experiencing an improvement in feeling. So when you test them with the monofilament before Vacuumed therapy, and you do 5 or 6 sessions and even longer, sometimes 12 sessions, there is an improvement in their neuropathy when measured with a monofilament. Okay. And we also saw the athletes are healing faster. So I wanted to show you the current cases, and I've been seeing this patient very recently. And why this case is for me very important in where I work, a lot of orthopedic surgeons don't believe in IVT. And one of our biggest troubles is if you have a traumatic fracture or a split fracture where there's fragments involved, your risk for infection, your risk for amputation increases. Now this patient is not an easy patient. In January he fell, fractured tibia and fibula. They then did subsequent instrumentation, and after 4 weeks, he decided he feels so much better, he can walk on his foot. So he broke it again. Okay. So again, they had to redo that. That's any surgeon's nightmare, mine too. So 4 weeks after that, when he came in, there was wound dehiscence. So there was slough, there was infection, everything that you don't want in a leg that's already been through trauma. So when I got to him, it was just a few days before this photograph, let's say a week and a half before that. We first had to debride, get rid of all the necrotic tissue. But we also started immediately with IVT in this patient. So the biggest challenge here is, if you look closely, you'll see there's instrumentation open at the top hole, as well as you can see 3 screws in the bottom here, and this was all communicating. So we were worried that this was going to dehisce even further, and we sit with an open area. We also had undermining underneath that area, and quite a lot of exudate. The exudate that we could see from that was the same color as what you would see here lying in the wound bed there. It's a purulent color, a lot of drainage, and we were very concerned about this patient. So we started off with conservative wound care, and we did IVT. That was the main treatment there. So what you can see here, this is now a little bit more than a month later. We have granulation tissue over instrumentation and overexposed bone. It's almost completely closed. The last little bit has to, I've seen him Friday morning. That's now completely closed. Unfortunately, I didn't bring that picture with me. So all that we've got now is we can either do a skin graft, just close that area. The exudate is also much less. Or we can just give it a chance to do its healing on its own, which I will probably would like to do with him to have no risk of further hospitalization. But to me, this was really a good result in showcasing you what we can do with open bone, open instrumentation. So this was the one that I spoke of earlier. I would like to introduce you to Chris Wright. He's probably a spokesperson now for IVT in South Africa. This patient has motor neuron disease, 7 years. And he's actually a miracle walking still. He's already had one amputation, so we're only having the left leg that's there. He came in again on the 14th of May, and as you can see here, that was infection again all over. Temperature increase in the foot. Overall malaisis, he was not feeling well. You can see the swelling in the limb there as well. And here you can see 4 days later, look at the difference in edema. Okay. We also use a total contact cast in a diabetic because for this patient, he cannot not use his leg. He's a mechanic. He's the breadwinner in his family. If he doesn't work, they don't eat. So we need to work with the circumstances here. And the only way that you can get a diabetic back on their feet is by using the gold standard, which is total contact casting. So he was in his cast, working on that foot, having IVT, and you can see this. He had 2 sessions. Look at the difference in the foot and in the leg. I'm not excluding what the beauty is of total contact cast because that does play a significant role as well. But IVT helped us to get the inflammatory process under control. It helped us to decrease the edema. It helped us to enhance his capillary flow as well and regeneration. And I firmly believe this is probably the fastest results we've ever had with this patient. If we can go to the next slide, Gabriel. So for me, this is kind of an iconic picture because he's got one leg standing outside of the vacuumette, and we're trying to save the remaining leg inside the vacuumette. And this is really what we can achieve with this device, is you can actually give patients their life back. This picture is not yet smiling as much as he's smiling now. So I'm sorry I don't have the smiling picture for you, but at least it shows you what we started with him. But this is a significant result. Gabriel, you can go to the next slide. I had to include just a ligament tear, just for the sake of it, because we do treat that as well. And this was actually a study that my daughter did for their school project, where they invited their own school scholars to actually say, if you've got any ligament tears, you can come have sessions. They wanted to see if it will really work. So my own family didn't believe it until they did a test. Okay. So this was just 6 sessions in this patient. You can see it was on the 29th of March, 31st of March, and the 6th of April, the last session. This is a young rugby player, a high school rugby player. But the result was really significant just from the photographs. And he's back on the rugby field. He's playing his heart out at the moment. And that's what you want. You want faster recovery for these injuries. It's not a miracle treatment that when you have the injury today, you go into the vacuumette and tomorrow you're healed. That's not what we're saying. But if you can rehabilitate faster, you get much better results. Okay, Gabriel, next one. Oh, yeah. So I'm finishing off. In South Africa, we've got the concept Ubuntu. It means working together, and I am because we are. And we can say that for the collective community in IVT worldwide. Because we actually share each other's knowledge, we share what we found with the technology, we can make a difference. If you don't share what you know and we don't discuss our different cases, how can we learn more from this therapy? There's still a lot more that I want to explore and learn more about. The nitric oxygen makes sense to me because of what happens to my patients and because of the inflammatory process. So for me, I really would like to work more with that and see the physical results. My question always with this is how do we measure? How do we actually state what we found? Because a case study and a case series is wonderful. But if you don't have good measurable items to say what you've measured, like for instance doing either transcutaneous oximetry to prove the blood flow, or an ankle brachial pressure index to say what has happened with your arterial perfusion and your venous return, we cannot justify that always in the medical world, and we need more studies. In my environment in the wound care arena, certainly people are starting to say, okay, there's maybe something here, but they want evidence. They want peer-reviewed, published articles, not just case studies. So even though I did an 82 case series, it's not enough because they want to know what was the transcutaneous oximetry measurements, they wanted to know more about infection, they wanted to know values, and that's what we need to give the medical environment. So it's all about working together. Your patient needs to work with you. If the patient does not understand what you're doing and why you're using IVT, how can you expect them to comply? It's the family members. Get them involved. Let them understand what's going on. I often let the family members sit with the patient so that they can see it for themselves. Or sometimes I let the family member have a session for only 10 minutes or so that they can experience it themselves. The community. Ironically enough, my best way of advertising is my patients. They talk. Okay. The healthcare provider. The team that you work with, do they understand the technology and the benefits as a team? And that's very, very important. And then, of course, do you understand your technology? Because it's fine to use technology, but if you don't know where to implement it, you can't. Can you just put the last slide on for me, Gabby? And then I would like to finish off and say in Afrikaans we say dankie, which is the same as thank you. So I've taught you a new Afrikaans word. The other Afrikaans word that we say is lekker, which means it's very nice. So I do hope you have a lekker time here in Moscow and that we have a good day further. Thank you very much.
У меня к вам есть вопрос. Это из Казахстана, меня зовут Майра. В общем, я хочу спросить, при выборке больных вы были ли больные с нефропатиями? Первый вопрос. Причем какой стадии? Второй вопрос – это были ли у вас пациенты с нарушением ритма сердца, типа как мерцательная аритмия? Вы брали их в лечение или нет, группу?
Okay. So first of all, when we screen our patients, I am very concerned with cardiovascular disease. So if a patient is in cardiac failure, I will not use the vacuumet for them because you've got a risk of shifting a high volume of fluid through the heart. So if they've got edema because of cardiovascular disease and heart failure, I'm very hesitant to do that and I exclude them from that. So arrhythmia patients, I've had patients with, what do you call it, a pas-aangeer, pacemaker in, no problem with a pacemaker. But in general, I would just make sure about cardiovascular disease first of all and heart failure. That's the main thing. If they've got heart hypertension or flow problems, it's not an indication. If they are under treatment for the cardiovascular disease and it's monitored well and you work with the physician, I don't have a problem. I've treated patients like that. Most of your patients, especially the elderly, will have some kind of cardiac failure. It's how bad that is that you need to look at. With regards to neuropathy, I treat that most diabetics has neuropathy. So we'll have neuroischemic patients, we'll have just plain neuropathy patients. This patient that you saw last has neuropathy, but because of the motor neuron disease. So I treat all different types of neuropathy. Does that answer your question?
Неужели вы третью степень брали? Нефропатию я имею в виду. изменений со стороны почек? Не было ли осложнений?
I've only better results with that. So I had one diabetic patient with renal failure that was on the brink of going into dialysis. And that patient specifically, what was interesting, her renal pathology got improved while on the vacuumet before. And so they actually delayed dialysis with this patient. But I haven't treated a patient who is on dialysis with the vacuumet yet.
Еще один, извините. Третий вопрос такой. Вы это учитывали гликированный гемоглобин? То есть вы же брали больных с сахарным диабетом же, я как поняла. И у них были, то есть компенсированы ли были больные?
Yes, that's one thing that I really enjoy about the vacuumet is that you actually lower their blood sugar. But be careful with that. So 2 weeks ago, I had a patient with a blood sugar of 22 millimoles. And what I didn't know was that just before she went into the vacuumet, she injected 15 units of insulin. So she went into a hypo. So be careful when you do that because it will lower the blood glucose. I've done blood sugar analysis before and after vacuumet with several of my patients, and we tend to lower the blood glucose by at least 2 units. I assume that answered the question. Any other questions? I assume you all would like to have some coffee now. Thank you very much.